do some more, so at the end, I'm happy to give those to those who did not get a copy, okay? I'd like to introduce, which needs no introduction, Dr. Jeffrey Wilson. He's here speaking at Osteoporosis 2023 today. So let's give him a warm Westminster Canterbury welcome. Thank you. And keep in mind when we have questions, I do have a microphone to go around, so if you could wait till I get to you so we can hear that. This is being recorded for our resident website as well, so we want to be able to have all the information on there. Thank you. I'll hand it over to you.
Let me have the first slide. Let me have the first slide. You can handle it?
Yes.
Okay. Became interested over the past year and a half, particularly in the osteoporosis presentation. Things are changing a little bit. One of my front office gals who had gone through a bout of breast cancer several years ago called, and she had been out on Smith Mountain Lake, and her husband was driving a boat across real fast, and boom, she got hit with back pain. Well, she'd been on a aromatase type inhibitor, so an anti-estrogen medicine that really predisposes you to problems like osteoporosis and compression fractures. So indeed, she had a compression fracture. Well, I thought, well, she's young, and eventually she got on a medicine taking care of that. Don't know why she wasn't on it before. And then, later on, had another patient that I heard about, here in Westminster Canterbury, and she had been on medicines and so on and developed a compression fracture. She thought it was just a little back strain. Well, it didn't bother her, and initially her doctor kind of followed her along. It wasn't until a little bit later as the back strain persisted. Then I was over getting physical therapy. Jackson was putting me through the mill, some of my Parkinson's exercises. And at the same time, Colton was working on one of our ladies here. She likewise had a back strain. This is what introduced me to the new thing, Westminster Canterbury back. The back strain it continued to be a problem, not terribly bad, but bad enough that she stopped her doing things she wanted to do and felt that she had this compression fracture. So it got me thinking a little bit more about what's going on. And if we take a look at sort of the history of the osteoporosis story since I've been in practice, about the first 10 years, I would get a call maybe 4 or 5 times a month about one of my patients in the emergency room with back pain. And they'd say, one of your rheumatoid arthritis patients is here. I think they're having a flare of their arthritis, real bad back pain. Well, rheumatoid arthritis doesn't affect the back. Other types of arthritis might. Went over, and it was always maybe an early compression fracture. Something was happening. And at that time, a lot of the patients were on prednisone, steroids, which predispose you to, problems with osteoporosis and these sort of fractures. And really, at that time, there wasn't much more you could do other than symptomatically take care of the back pain, muscle relaxants, pain medications, heat, calcium, vitamin D, those sort of medicines. Vertebroplasty was being looked at where they would actually inject and re-expand the compressed vertebral body. At that time, when people had hip fractures, we thought the patient fell and had a hip fracture, and in truth, you'd say, well, no, the bone broke, and then they fell down from the osteoporosis. And it was a serious problem. People were going home without any follow-up in terms of osteoporotic treatment. And only about 50% of them, or less than that, went back to independent living after they'd had a hip fracture. And then the next 2 years after that, there was about a 24% mortality among those patients, those individuals. So it was a serious problem. Then in the 1990s, we really got into the era of osteoporosis investigation. And the first things that came out were the bisphosphonate medicines, which you may have heard of, and probably Fosamax, the earliest one. And those medicines were very helpful and did well. They were the first agents. Had some problems with them. Next slide. Okay, and one more. One of the first things that occurred was problems with the tolerance in the esophagus with the medicines, very tough on the esophagus. Esophagitis, very common. Then they could develop some of these ulcers and sores in and around the esophagus, which you're seeing in that picture. Now that problem was taken care of nicely by, instead of the patients taking on a daily basis, they were taking the medicine once a week. I had my mother on this at that time, And she was taking, when you took the Fosamax medicine, you had to stay upright, lots of water, get it through your esophagus, and have it absorbed as well as it could. And don't lay back down for about 45 minutes. So it was a real pain to take. Then when they went to the 70 milligrams once a week, and my mother said, "You mean I'm going to have to take 7 of those pills all at once?" I said, "Well, no, they're going to make a 70 milligram pill." Very convenient, very nice, well tolerated. But the next thing that showed up was a problem with osteonecrosis of the jaw. If any of you have all had dental problems, particularly involving the bone in the mouth and the jaw, it's a bad problem. Let me have the next one. That problem was bad enough, but usually what you did with your patient was you had them seen by the dentist and got their dental care really up to date before they started the bisphosphonate medicines. Go to the next slide. The really unusual thing was a killer for some of the medicines. We talked once before about nocebo effect, where people in the news or somebody start to report bad type problems and complications, and then you have less and less faith in the medicine for sure. Well, one night Diane Sawyer got on CBS News, and there was a big problem with these atypical femur fractures, and they take a look at the big, large bone, the femur, breaking right in two. And this was occurring in our patients, and she particularly noted and mentioned Fosamax for Merck. Their stock went down about 30% in one day. And what they found out over time was that this really was related to the duration you're on the medicines. If you went every 3 to every 5 years, they now would stop the medicines, the bisphosphonates, and go ahead and have you take a drug holiday. At the time, this was most prominent problem. The fellow people who do academic medicine were seeing this maybe, one of these every five months. Now it's like one every 3 years. So it made a big difference in this drug holiday. You don't take it all the time. So the question was, what could we use in place of it? The next slide. The studies that were done during this time gave us a chance to get some basic definitions, which I have written for you there. And osteoporosis, skeletal disorder, compromised bone strength, predisposing to an increased risk of fracture. It's a lifelong chronic process. It requires long-term treatment. The bone strength, which we're most interested in, is looked at 2 features: bone density, which we can measure. That's the DEXA scan, which many of you have had. And then the bone quality, which is difficult to measure. They can do some specialized X-ray evaluations of that. Sometimes did bone biopsies. One of the things that was dear to my heart was if you took a look at all of the research being done on the bisphosphonates, the one thing that had to be done was they had to make sure the vitamin D was normal. Because if it wasn't, that was one of the most common causes of people not responding to the bisphosphonate medicines. We talk about the fragility fracture. This is the one we worry about when all of a sudden the person falls and something's broken. And they used to say it was related to somebody who broke a bone when they fell less than the height of their body. Now I think basically the fragility fracture is anyone that seems to have less trauma related to it, or atraumatic type etiology behind the fragility fracture. It's the low trauma fracture. When your bone develops, your skeleton develops, I think we feel like you have a set down of the permanent bone structure. But in truth, the bone is always remodeling, about 5 or 10% remodeling a year. And therein lies the problem, balancing the resorption with the formation. The osteoclast are the cells which are responsible for the resorption. Osteoblasts for formation in bone remodeling. The next slide. And normally, if you take a look at the bone mass development and so on, it peaks at around 20 years of age. Remember that? Then it's stable till you're about in your 40s. Then about 0.1% to 0.5% decline yearly, so the resorption is greater than formation at that time. females start off with a lower peak mass, bone mass, and the postmenopausal occurring loss of the estrogen effect, about 4% decrease yearly, 1/3 to 1/4 of the bone mass lost in the first 7 years post-menopause. So the anti-resorptive effect of estrogen is lost. In the next slide. Osteoporosis is one of 3 diseases we consider as part of the metabolic bone diseases. Osteomalacia, we've mentioned before, is one related to vitamin D deficiency. If you have that as a child, it's rickets. As an adult, it's osteomalacia. As that's developing, it's painful. And we used to say that the trouble with osteoporosis was that it was developed and was not painful. So it didn't show up symptomatically until it was very late and you were starting to have fractures. And so that's probably not true, and that's one of the main things that we'll kind of emphasize in looking at the back problems. There are things that are minimally symptomatic, but still really important signs of osteoporosis. Paget's disease, interesting. It's a disorganized resorption and formation balance, and can be symptomatic at times. The next slide. If you have been to the hospital or been to the emergency room or your doctor's office with back pain, they just do some routine back films. And it was amazing. I remember seeing our patients in the emergency room, again, rheumatoid arthritis not affecting the back, but they would have lumbosacral spine films. And sometimes you look at it and say, boy, your back must have been bothering you. It must have been hurting all this time. So no, really didn't have anything but some back strain every now and then. Well, something was happening because you're beginning to see some changes in the vertebral bodies of old compression fractures. Very common change and finding on the routine X-rays. They feel like once you've had the first vertebral fracture, that 25% will have a second fracture within a year. And you probably ought to have these vertebral X-rays, back X-rays, when you're with females greater than 65 years of age, males greater than 70, or if you're on steroids using more than 5 milligrams for about 3 months, or if you measure loss of height. If you think about what's losing your height, if you have compression of the vertebral bodies, obviously you're going to lose some height, sometimes curvature of the body, kyphosis, and so on. Give me the next slide. Here would be some routine X-rays. If you follow down the upper arrow, which is open, that's in the thoracic vertebral bodies. And some of those show some compression, but not too severe. So you get down to you see the first solid arrow, and that vertebral body is squeezed way down, and compressions other areas as well. Some of them have just where they're starting to squeeze down, so that bottom arrow that's open, the vertebral body is compressing but hadn't turned into complete compression and fracture at that point. The other thing about height loss in general, no one gets taller as they get older, except Angie, I guess. But if you do get taller as you get older, you got a different problem, and it's not good. Because usually your intervertebral discs are about 90% water, and as the time goes by, they dry up, and so you have lost those degenerative disc disease and osteoarthritis related to that. So we were familiar that this is very common to see these changes, and they end up being very important in terms of all your basic function. Vertebral compression fracture that occurs can have a significant decrease in the vital capacity if somebody has a chronic lung disease, COPD. And maybe many of us would have a compression fracture. It didn't make much difference, but with someone with this compromised respiratory function, it can be quite a problem. I guess the most important new idea that came up is that if you have vertebral fractures like this that are unrelated to major trauma, didn't have any bad problems that could explain them, that is as good a diagnostic aid of osteoporosis or sign of osteoporosis than the DEXs and the T-scores and those the other studies that are done. The next slide. The bone density, which I expect most of you have had, shows the relative risk and shows some treatment response. And the DEX is the dual energy X-ray absorptiometry. T-score -1 to -2.5 is called osteopenia. Okay, so you're thinning what you expect to do as time goes by. Hasn't reached the extent of being osteoporotic. And the vertebral fractures, again, unrelated to the major trauma, are are diagnostic of osteoporosis. So we need to be aware of them and treat them. Yeah, the next slide. And the treatment's kind of interesting. Anybody need a swig? Things you can do as far as treatment, lifestyle modifications, cutting down on alcohol, and certainly seen some problems with bad osteoporosis there. Smoking, interesting cause of problems with osteoporosis. And if you remember years ago, the main place in Lynchburg that had the oncology unit was Virginia Baptist. Wilbur Berger had set that up and started really oncology in Lynchburg. And when I would go on the wards at night and go by the oncology ward, perhaps see a patient, when you go in the nurse's lounge, guess what? Smoking like crazy. And you thought, you know, how can you be out there taking care of all this cancer problems related to smoking and be smoking? Well, probably different reasons. But then an article came out in New England Journal. It was really interesting. It showed a decreased cancer effect or people that were smoking. So, gee, smokers have less in the way of cancer. Why is that? Well, it's an anti-estrogen effect. And the smoking, what they found out was that the patients would not stop smoking because of cancer risk. But you say, this study in the New England Journal showed that people that have that with the anti-estrogen effect have more facial hair. Now the nurses were stopping smoking. Say, don't care about cancer, I'm not going to have that facial hair. Charlie Driscoll mentioned in his last talk about with dementia, all that low body weight can be associated also with as a factor and predisposed into more osteoporosis. Immobility, patients who are just put in the hospital and will have sometimes elevated calcium levels in their blood, but also they mobilize the calcium in the bones, and osteoporosis, tends to get accelerated. The various medicines we see, and we've listed there several of them. Steroids certainly the most common, but anticonvulsant medicines, aromatase inhibitors, and some of these medicines are used injectable, like every 3-month type of things for birth control. All of those have had effects. Gravity has an effect. So if any of y'all are thinking about going up in the ship, buying one of those rides, that will be a factor. It will make you accelerate your loss of calcium. And the next slide. The pharmacologic therapy, really two basic things. One is you want to decrease the resorption of the bone, and the other is to try to build up bone antibody. In anti-resorptive medicines, estrogen, raloxifene, Evista, calcitonin, those were sort of minor medicines that were helpful as far as osteoporosis, but really got into the Fosamax and the bisphosphonates, which were very helpful and effective, except for the problem every 3 to 5 years of maybe having the tendency to femur fractures. The Prolia is a very interesting medicine. It's a anti-rank ligand antibody. It's called denosumab, and it blocks the osteoclast, the resorptor. So in other words, to protect the bone, it's going to decrease the resorption. Quite effective. This new medicine, I've never used it, never heard of it until getting this talk together, sclerostin inhibitor, and that is it decreases the chemicals, the activity that keeps the bone more together and allows it to be mobilized more when you're having the bones are remodeled. Anabolic medicines like Forteo, teriparatide, Timios are injectable medicines. They'll be on it for maybe a year or so, daily injection, very effective and did indeed build the bones, help with that. Okay, now the next slide. Here's a typical history. Now I'm not going to use any names because of the initials. Instead, I'm going to say that LH could be L. Hunter or Laura H. BB could be Bessie B. Could be B. Burton. But I'm not going to say. But this may be part of a common Westminster Canterbury story. Our patient is in her mid-70s, female. She's in the Azalea Club about 2 to 3 years. And then she got a call from LH. We have an apartment, a cottage just for you. And she thought, well, that sounds good. She had seen several of them, and they weren't quite right. This was the one that she thought was going to be correct. So she went ahead and said, we'll do that. Not worried, because she's been in this house 45 years. There's no rush. She'll have months to go ahead, right, empty the house and take care of things. No. Instead, 2 hours with LH that week, and she picked out everything. Appliances, floor, colors, you know. She said, well, okay, those things will be taken care of. I'll still have 6 months to empty the house. No. No, you don't have 6 months to empty the house, figure the furnishings, paintings, do artwork. No, BB and LH have the movers come in about 2 days. Sounds familiar. So what you say is, I'm packing, I can carry one more object in this box. I can just go ahead and just do a little bit of back strain, because I haven't been doing it for 50 years, but I can do that. And you didn't want to do it, because then you start into the back strain and the development of the compression fractures. To the next slide. Even though you get your son to come over and try to carry the boxes for you, he still gets into the compression fractures. That is the Westminster Canterbury back that we have. And again, it's a chronic process. How do you avoid it? And when I was over there, having Jackson working on me, and Colton was working on one of our ladies who had gone through this exact experience, and starting through the exercises. I'd be interested to hear, what sort of problems you have had as far as osteoporosis, and what things are being done. Because I think we were evolving particularly toward the use of the denosumab, the Prolia. And that probably looks like it's the two fellows who do the most research that we read in rheumatology, Paul Taylor and Mike McClung, feel like you could probably use the Prolia indefinitely, and then that's an injectable about every 6 months, and not have to worry about rebound and so on. Others, if you're put on steroids, they probably put you on the bisphosphonate medicines, to protect you from that. I mean, the steroids are always a big problem with osteoporosis. So I'm going to open up for questions for you all about your osteoporosis findings, questions, and then we're talking about something else.
We've talked in the past a lot about the role of calcium as being helpful with osteoporosis, but I know one of the gynecologists too recommended not doing it, and I think what he was probably worried about was that one of the things cardiologists look at in assessing coronary risk is a thing called a calcium score, which is a non-invasive way of estimating the calcium deposits in coronary arteries, and it's thought that when coronary arteries become narrowed, you can get a bunch of calcium in there. And I think he was worried that people are on a lot of calcium supplements. This might increase coronary risk because of buildup of calcium. I know I've always kind of made a point before putting somebody with calcium, trying to check serum calcium level just to make sure they didn't have an elevated calcium for some reason. Made me a little nervous putting somebody on calcium if it was already elevated. Plus, one needs to find out why is it elevated. Do they have hyperparathyroidism or malignancy or whatever, but I wasn't quite so attuned to it being a coronary risk, and I wonder how do you balance that? I think people have felt for years that taking calcium helped with osteoporosis, but yet we don't want to increase risk of coronary artery disease.
Yeah, I think the general thing I always saw recommended was about 1,000 to 1,500 milligrams of calcium with vitamin D supplementation. Seemed to be sort of standard, and I don't remember having much in the way of problems unless there was some underlying thing like hyperparathyroidism or cancer that might, predispose to calcium problems. But it's always, I always feel like about every 6 months when you're on some regular medicines, it'd be nice to know what your blood count, liver, kidney function, things like calcium are doing, because we're dynamic, we change. The thing you tolerated 6 months ago, maybe you don't now. So look at those things. The government may not want to pay for them, but I think that's the sort of concern you have. But so calcium, vitamin D, and then some people feel like they're helped by magnesium, other elements like that. We always had that pretty standard, and then we just continued that. Once we got the bisphosphonates that into the basic diet and all.
So it doesn't sound like increasing the risk of coronary disease is really, you found that to be a big issue with calcium and the doses you're recommending.
Yeah, I think always being aware of it, but that didn't seem to be a big problem with our folks.
That's good. Thanks.
Shannon.
One of the concerns about Prolia is what happens if you stop it. It's a skeletal or spinal collapse. Would you talk about that, please?
Well, the fellow I mentioned to you, Paul Miller, he talks about that, particularly at the conundrum and so on. What they found out is that it may for a while seem to go down, it's just protection, but it seems to come back. And they, to me, most of the time weren't even covering, and I did not, cover with that bisphosphonate, but some people were doing that for a while, going to bisphosphonate for a few months, 6 months or so. So but his final feeling was that may be the ones you can take indefinitely. I don't know. Have you had any experience or?
No, just it's a scary line in the description of the drug.
Well,
And what was that drug?
Prolia.
Denosumab. And they have a wonderful series of lectures by Paul Miller. He's out of New Mexico, Arizona, on the osteoporosis medicines. And following these people along, how well they have done with going chronically with the denosumab. But he has some information about that, which I don't have.
Hi. At one point, when I did a bone scan, it said I had osteopenia. The next time I did a bone scan, it said I didn't. So I was fine. So then recently I had, my knee was hurting, and I went to the doctor, and he said I had a stress fracture, which showed all the, I guess I had bone loss or whatever in the knee. So I had another DEXA scan. Now it said I had some osteopenia, and to do the 1,200 milligrams of calcium a day. So I don't know. It's I always was concerned about the heart with the calcium too, and I take lots of supplements. And I use magnets, and I wear magnets, so I don't have any aches or pains. I was just walking too much, stressing that knee, going down 6 flights of stairs and walking 5 to 7 miles a day, and then it hurt my knee. So, it's a fine line. You think you're doing well for yourself, and you may or may not be. So.
Well, we know the demands that dog is putting on you, but it's worth it. Yeah. Crystal clear, huh? Caroline?
How often should we get those bone scans? If we say we already have osteoporosis, is there any need to keep getting them?
It'll tell you if you're improving or not. And and we I've done it every 6 months, However, the government, of course, doesn't want to pay for any of them anytime. And Paul Miller points out that was one of the big initial problems when they decided instead of paying $100 for bone density to go down to $35. And so that's how they control cost. Bogus, but it's effective. How many are up to date as far as like DEXAs and sort of thing? Any men had a DEXA?
Are there 2 or 3 things that you could tell us to try or to do to try to prevent osteoporosis, or however you say it? Yes.
Well, I think first of all, activity, walking and exercising, or anti-gravity type stuff. And other than, a balanced diet, I don't think there's anything more specific. I suppose there's some question about how much, sun and vitamin D we got from sun. I know Dr. Hickman, big proponent of a lot of sun for your vitamin D. No.
Easier to swallow it and much safer.
So those things are sort of up in the air.
How much vitamin D are you recommending now?
We did about 1,200, and had I think one of the caltrates had calcium vitamin D combination.
Yeah, I know. So how much vitamin D should you be taking?
Oh, vitamin D?
Yeah, D.
Well, if you do not have any problems with it, I like 2,000, the D3, daily. But we also had people up to 5,000. The most amazing thing about vitamin D is how it's inherited metabolically. As you see, particularly young black, patients with lupus in the family, and they would have incredibly low vitamin D. You'd have them on the prescription vitamin D, the 50,000 once a week, and every day 5,000 D3. And the whole family member, same thing, you had to get those to get their levels up. Interesting.
One of the residents was telling me the other day about a patient on Prolia who started on Prolia and developed all of these terrible, like flu-like symptoms, and just felt terrible and wasn't doing well at all. And she stopped the Prolia. And I just wondered, have you encountered much in the way of people developing all kinds of symptoms and side effects with Prolia?
Well, I want to just one that's very contrary. My patient that had been my front office gal for years, who had the stress fracture from going across Smith Mountain Lake in the setting of the aromatase inhibitor and so on. She's allergic to everything. And it said, Scarlett, I'm going to try this additional medicine. And I can't take any medicine. I can't take any medicine. Talk about nocebo effect. Tolerates it beautifully. She's healing her back. And so it's been very well tolerated. But just like everything else, remember what do they say on TV? If you're going to have a fatal reaction to this medicine, don't take it. Well, how do you know? But in general, we feel that's true. Don't take it.
It might have even been something else that caused it.
Oh, sure.
It may not necessarily been the Prolia, but I was just wondering if you. That sounds like you haven't really encountered that very much.
No. How about you?
I haven't had a lot of experience with it because I'm just helping them with their patients now. And we didn't have this when I had my own panel of patients, so I'm still kind of trying to get a handle on, the appropriateness of something you're.
More of those monoclonal antibodies, huh?
Yeah.
Oh, yeah.
Any other questions?
If we don't, then I wanted to have some time to point out a couple of things, and that is, I wanted to review with you some of the rheumatology that I've encountered just in the last 2.5 years, because it's going to be important. There are things that are going to happen to you in the next few years, so just be ready. First of all, some of you are going to have the experience where you get up in the morning and it feels like you've aged 100 years overnight. You're so stiff in your shoulders and your hips, and that's the thing called polymyalgia rheumatica. And it's something that usually the patient's over 50, saturate's over 50, they respond to very low dose prednisone steroids, and that may go ahead and resolve sometimes over 12 months, 18 months. Everyone's a little bit different. But if that's in the family, then you and your family members are more likely also to have sort of a related disorder called giant arteritis or temporal arteritis. So now the next thing that's going to happen is you're going to say, gee, I've got this new headache, different type headache. It's not the blasting headache that's the worst thing you've ever had, which just makes you worry about aneurysms and bleeds and so on. But with that headache, you may have some tender areas in the scalp to touch. You may be noticing some pain in your mouth when you chew your food. You may be having a temporary loss of vision one eye or the other. Well, this is trying to evolve into a thing called temporal arteritis, giant arteritis. This can kill you, make you blind overnight, and so you can avoid these sort of things. Your doctor needs to know, check the SED rate, always greater than 50, and this requires higher doses of steroids to contain, but can prevent the blindness, sudden death, and so on. And we have seen some of that. We'll see more of it. The polymyalgia rheumatica, interestingly enough, as somebody knows in here, can be the presentation of tick disease, alpha-gal tick disease. And you think, well, wait a minute, this is alpha-gal, and you're not responding. The PMR is not responding quite as well as you think with the prednisone, low-dose prednisone, and indeed, with the infusion of red meat, all of a sudden you're much worse. So alpha-gal tick disease, which we know is more common than any other tick diseases. Here at Westminster Canterbury, we've seen patients with that. I say patients, I must just say fellow residents with it. And they having to follow the diet, cut down on the meat and so on. Always aware of it. I had one patient who had a combination of Lyme, Rocky Mountain spotted fever, and alpha-gal. She got a lot for her money. The other thing that can occur sometimes with the temporal arteritis, giant arteritis, a thing called pulseless disease, and have a individual that's got a sky high SED rate, and misses in a pulse in one extremity, and I've had patients like this in my practice, and you're always worried that they're the ones that are going to go ahead and have a stroke or sudden blindness and things that can be avoided if you're aware of it. Now, the other things as far as basic aches and pains with weather changes, well, welcome aboard. Things we try things that are safe to take and not too problematic. So one of you over the next year or so is going to have a thing where overnight you're going to develop just diffuse swelling of the arm, elbow, wrist, something like that. This is going to probably be febrile. You're going to feel really systemically sick, and you need to go to the emergency room. The orthopedic surgeon needs to look at it because you're having an unusual infection starting into your system, necrotizing fasciitis. Remember the old thing about the staph type disease they worried about, and when this occurs, it has to be opened up and so on. But it's very important to do. Can't mess around with that. You don't go to the doc in the box. And the orthopedic surgeon needs to be aware and ready to open up and take care of necrotizing fasciitis, bad infection. Any other questions?
Thank you, everyone, for coming. If you did not get a copy of the outline and the information that Dr. Wilson gave at the end, I have more copies here, so you can get them before you leave. And this is also going to be on the resident website. This lecture will be on the resident website. I will also have copies if you hear anyone that was not here that will be seated on the resident website. If they want copies, I'll have them in the Wellness Center. Okay? Thank you. Have a good day. Thank you, Jeff.